Hello and welcome everyone, and thank you so much for joining us today. My name is Jennifer Noel, and I'm the Program Manager for the Education and Outreach Core at the University of Vermont Center on Rural Addiction, which we call UVM CORA. And UVM CORA is also a Rural Center of Excellence on Substance Use Disorder Treatment. I'm here with Center Director, Dr. Stacy Sigmund, and Education and Outreach Research Assistant, Eleanor Broy, who will be helping to facilitate this webinar. As you are entering the session today, you are automatically muted and your cameras are off. So today's webinar is entitled Recovery Housing as a Bridge to Aligning Social and Medical Interventions, which is presented by Milena Stott and Erica Walker. The Community Rounds Workshop series is a live webinar series hosted regularly by UVM CORA, and our goal is to provide opportunities for health professionals and community partners to learn and ask questions. We discuss topics related to science-based best practices for substance use disorders. Before we get started, we do have a couple of reminders. And we encourage you to ask questions. So feel free to enter them into the Q&A box that's probably at the bottom of your screen, which we've pointed out with that arrow. And we will review your questions during the Q&A portion of the webinar at the end. The session is being recorded, and the recording will be delivered along with the slides to your email inboxes next week. We also want to let you know that after our speakers have finished their presentation and just before we have our Q&A session, we will share a very short poll to assist us with our evaluation. And you're going to see that right in the center of your screen. We'd love to have you fill that out. It should take about 1 minute. And so if you're comfortable, please use the chat box to introduce yourself to the group by sharing your name, your organization. You can tell us what you do at the organization and the community that you're coming from. I know people are here from all over the country. We're also grateful for any comments that you'd like to share with us in the chat about the webinar itself. We always love to get feedback. And be sure to select everyone when you use the chat feature so that other participants can see your comments. We're pleased to offer live captioning for today's event. And to access the captions, please see the chat. We will provide a link for you. Continuing education credits are available for both those who attend this session live and those who watch the recording within 1 month of the live event. During the session, we will share the link in the chat box for instructions on how you can claim your credits, and you will get these same instructions via email when you receive the recording and the slides next week. And if you have any questions, you can always contact us at cora@uvm.edu. There are no disclosures for this community round session, and all potential conflicts of interest have been resolved. So I'm going to stop sharing. I'm going to let our speakers share their slides. And while I'm doing that, I'd like to welcome Dr. Kelly Peck, who will be introducing our speakers today. Dr. Peck is the Director of Clinical Operations for the UVM Center on Rural Addiction. He is also an assistant professor with joint appointments in the Departments of Psychiatry and Psychological Science at the University of Vermont. Dr. Peck, I'll hand it over to you.
Thanks, Jenny. Welcome, everyone. It's always cool to see where people are coming from and enjoy reading that in the chat. I'm happy to welcome our speakers today, who are both coming to us from one of our partner organizations, and that is the Rural Center of Excellence on SUD, or Substance Use Disorder Recovery, at the Fletcher Group. So Milena Stott works with housing authorities, housing operators, and Medicaid agencies to expand and finance recovery support services. Building on management experience as a strategist and innovator in integrated health systems, she helps organizations implement programs and reimbursement strategies that integrate housing into value-based insurance contracts. As a dually licensed clinician, her relationship skills and systems approach are especially useful in addressing challenges in rural communities. And then our second speaker is Erica Walker. She is a clinician and shares some interests that I have. So I'm excited to hear their talk today, which is she has a decade of experience supporting those affected by substance use and trauma, which is, I think, an important topic. She's passionate about integrating clinical services with recovery housing in the peer-led social model. She collaborates with housing operators and recovery support service providers with a focus on rural communities. Erica is Kentucky-based and has extensive experience helping organizations to identify resources and funding opportunities, engage local stakeholders, and manage operations and policies. So I'll yield the floor to Milena and Erica. Welcome. Thanks for being here today.
Thank you, Dr. Peck, and hello, everybody. It is a pleasure to be here. I am in the western side of the state, so it is morning for me, and I guess it's the lunch hour for those of you on the East Coast. So thank you for sharing your time with us today. I know I speak for both myself and Erica when I say that we're very excited to be here and speak on this topic. So during our conversation today, or our presentation today, we're going to talk to you about the support that we offer as a rural center of excellence so that you know how to reach us for support following this webinar. And then we're going to dive deep into our focus, which is really this concept of recovery housing as an anchor within the recovery ecosystem and how we use recovery housing to align social and medical interventions. And then we're going to talk about the systemic changes that support this alignment, because in an ecosystem, nobody works in a silo. And then at the end, we'll spend a little time focusing on, how the communities can come together to support people in rural spaces. So a little bit about the Fletcher Group Center of Excellence. A lot of our work is centered around a community catalyst. So one of our roles is to outreach to organizations and engage them in conversations about this systems approach. We really think that the boots on the ground approach is important in communities because you know the culture of the community, you have reach, and you're able to engage. We also focus on driving best practice and innovation. So we develop, implement, evaluate, and disseminate recovery practices. And in that space, aside from the development and dissemination, we also reach organizations and provide training and technical assistance to really help them develop these concepts. So huge focus on implementation and implementation science, the drivers of change. And then we complement that with research and evaluation, because we always want to know that what we're doing is working. Some of the areas where we offer technical assistance include, elements around development of housing and models of funding, working with criminal justice programs, doing community and environmental assessments, the clinical elements of trauma-informed care, medication-assisted treatment, community-based care, and then really how we use these recovery ecosystem and blend these clinical and social models of care in our continuum. And then, of course, paying for them becomes really important as well. I like to show this graphic because it shows our reach. It looks like we've got pretty good reach, concentrated reach in some areas. Some of what you see here is some of these areas are more rural than others, and because our focus is rural, you're gonna hopefully see more interaction there. And then I like to show this slide as an anchor to our recovery ecosystem model. This is really focused on the work of our research team, but it applies broadly to everything that we do, right? So we look at best practices and around recovery supports like smart recovery, engagement and retention, and contingency management. Those are interventions at the individual level. Then we think about the therapeutic alliance and interpersonal interactions and how people interact within their systems, like the recovery house, which is an anchor for their care. Then we look at how those systems look at or work alongside institutions and organizations, right? And how they're measuring outcomes and how we're providing technical assistance to institutions and organizations. A lot of the work that we encounter comes along with NIMBY and misinformation or lack of information, lack of resources. So a huge emphasis is also on community and making sure the community surrounding these individuals and organizations are prepared to support them. And then last but not least, we consider the policy environment and how our policies either enable or disable our process or by providing the funding and resources and legislative or legal guidance that drives our work. And all of those components become a part of this larger ecosystem that influences people's experience in their environments. So why talk about substance use and recovery housing? So the National Substance Abuse Survey basically identified that 46.3 million, or about 16.5% of the population, meet the diagnostic criteria for having a substance use disorder in the past year. And 94% of those folks did not receive any treatment. So we have high prevalence, low access. At the same time, we have a high number of overdoses that continue to increase. And we also have alcohol as a driver of disease and death and illness that we hear less about than the opioid crisis. It's kind of the silent killer, they call it in healthcare. And then on top of the substance use, you have folks that are living unhoused or experiencing homelessness. And maybe the definition of homeless varies a bit. And so when you include unstably housed or couch surfing or that sort of scenario, that number can grow bigger. But that's basically 18 out of every 10,000 people doesn't have a home. So what's the impact of all of this? I mean, there's the human cost of suffering and illness, which is what all of us strive to address. But then there's also the economic cost, not just to the individual, but to individuals surrounding them. And so the cost of the illness of substance use disorder, crosswalks or comes into contact with the criminal justice system, social assistance programs, societal costs, and these are all indirect costs that happen as a result of the illness. So we have lots of people who have a challenge, who have been identified as needing services, limited access, high costs. When people do get access, and I'm showing this chart to show you where they're getting their access. So when we look at the cost of substance use treatment in the healthcare system, most of that cost is happening in the hospital, in specialty treatment, or in specialty disease. It's not happening in community-based services. When you look at the cost of substance use disorders, you also have to consider all of the other conditions that coincide with that diagnosis. For those of you who work in managed care or have looked at data, you understand that a small percentage of individuals contribute to a large majority of the cost, and those individuals suffer from comorbid and complex conditions. And they often don't have access to, social and health services. And so their conditions continue to decline. And this is what we see as leading to the high cost in the medical system. So I took a class on value proposition and how you design services around the needs of people. In the marketing world, and when somebody's trying to develop a product, they do a lot of research on the needs of those on their customer segment. When we look at the challenges that are faced by individuals with substance use. And this is a international review here. You see that there's this kind of vicious cycle, right? That you may start anywhere in this cycle, or you may be born into conditions that are not favorable and don't give you the right opportunities for success, right? So your ecosystem or the social conditions for success weren't there. But what you see is that common things that you find with folks who experience substance use disorder is poverty, challenges with accessing gainful employment, meaningful wages. Maybe there's limited access to education. There's conflict in relationships, right? But these are common challenges that folks with substance use disorders experience. So when we're trying to design a service, right, that meets the needs of these individuals, those services can't be centered on the healthcare system independently, because that system alone isn't going to solve all of these things that the individual is experiencing. They are there to stabilize the substance use disorder, and often do so successfully, and then people exit into conditions that are not favorable for their recovery. And you see some of that cycle continue. That challenge is further exacerbated in rural communities, right? Because you have limited access, you have homogenous cultures sometimes. So if NIMBY is present, it's really there. There's not always interagency coordination and communication. The staff and workforce and resources can be limited. Transportation can, be a barrier as well. Homelessness or substandard housing. Motivation for change or isolation can be compromised, and then stigma and confidentiality concerns. So before we transition here, to Erica, who's going to talk a little bit about this model or service that is intended to address the needs of this customer segment that we're talking about here. I'd love for us to use our chat feature and let us know. One of the things that we're always looking for is information on barriers or challenges, so that we can continue to develop tools and resources and, promotional efforts around addressing those barriers. And so I'd love if you take some time to chat into the chat feature if there's any barriers that we haven't talked about. And Erica here is going to dive into some solutions that recovery housing can offer to some of the barriers we've identified. Erica?
Thanks, Milena, and great information. I see in the chat someone mentioned transportation. I can relate to that on every level because I live in a small rural community of around 6,000 people, and we do not have public transportation. So the nearest really SUD provider, and especially recovery house, is about an hour from me. So as you can imagine, that's a huge challenge in rural communities. Then there's kind of an education component that's being mentioned. Ditto on the transportation, internet. We are experiencing this challenge with a technical assistance client I'm working with right now that's having trouble getting internet to a beautiful new facility they just built. Engagement, peer-to-peer stigma. Oh, interesting. Oh, use of medications. Oh, that's a good one, Elliot.
Criminal justice expectations. That's another common one as well. Which is why that coordination becomes important.
Mm-hmm. Safe, sober transitions from housing to independent living. Oh, that's a good one. Criminal justice expectations. We have battled that long and hard in the state of Kentucky. Recovery residents is expected to play public safety role. Elliot, we need to get together and do a presentation. All right, thank you all so much for all that great feedback in the chat. I just always like to start the presentations, or at least my portion of it, with just some kind of leveling of like, what is recovery housing? Because if I see there's some folks in the chat who are either very involved with recovery housing, and then I also see some folks that look like, I love the diversity of professionals in the chat, by the way, but that maybe don't work around recovery housing very often. So I just wanted to start out with some basic definitions and information. And I like to start with the NAR definition for recovery housing. And you'll see the terms recovery housing, recovery residence, sober living used pretty interchangeably. And just also for further information, NAR is the National Alliance for Recovery Residences, a partner we work with frequently. And they're a national nonprofit who has developed the most widely referenced set of standards for recovery housing. And they also offer a certification process. And many states have their own NAR affiliate. Some states do not. Some states do their own certification process. And sadly, some states don't have a certification process. Some of them are working towards that. It's a really important piece. But oh, sorry, Milena, I went on too long and didn't get to the definition. There we go. But recovery residence really just describes a sober, safe living environment that promotes recovery from alcohol, drug use, and other associated problems. Thanks, Milena. And then again, if you're not working with the recovery houses, you might not know that there's really varying levels of recovery housing. So all the way from a level 1, which is the kind of least restrictive environment, like I shouldn't say restrictive, but that's kind of completely pure in. So there's not a ton of staffing and structure in the house. It's completely, again, pure in, democratically ran house, all the way up to a level 4, where you'll see clinical services and a peer-led component in the program. It's usually very structured and a full staff on site. And then in the middle, you have level 2s and 3s. And a level 2 will usually have at least one compensated staff member, policies and procedures in place. And then a level 3 will be more structured, have staff, usually more programming and support. They'll usually offer like a life skills course. My history early in my career, and what actually connected me with the Fletcher Group, was working in a level 3 facility. And as a person with lived experience myself, I realized when I started working at this facility fresh out of college that I absolutely knew nothing about recovery until I started working in the Recovery Kentucky model, which was also a model started by our chief medical officer and founder, former Kentucky Governor Ernie Fletcher. And the model was just so life-changing for me that I've continued this pathway and had a passion for recovery housing and the peer-led model ever since. And I'll share a little more about that as we go. This is just some of the recovery housing service mixes you may see. Not all of these are going to be offered in every recovery house, of course, and this isn't a completely inclusive list, but it's a good example of some of the things you'll see. For example, I was a case manager, so I offered case management in the recovery housing program I worked in. We also offered a full life skills curriculum. We did a lot of workforce development, helping our residents get connected to employment. You'll see a lot of mutual support groups, and virtually all of the different levels of recovery housing, you'll see mutual support groups. And you'll see also service coordination with medication supports, whether that's for mental health, for physical ailments, or for like opioid use disorder. You'll see the recovery houses really working to coordinate that care and to help them through partnerships in the community to be able to access that. All right, next slide. So why recovery housing? And this is probably one of my favorite topics to cover because I'm just so passionate about what it brings to the recovery ecosystem. But the first bullet here really says that the solution has to address the problem. And we know that substance use is really a chronic, progressive, and potentially fatal illness without intervention. So I would argue that recovery housing really does a good job of addressing so many of these like dynamics of the disorder. It really does a good job of aligning social and medical needs, which we're going to talk a lot more about. But some important things I don't think folks always think about is the long-term nature of it. We know with with the disease of addiction, it takes the brain at least a year to really start a good healing process. And recovery houses are usually long-term in nature, usually anywhere from 6 months to 2 years. So they give the person that opportunity to really begin healing and really getting a solid footing into their recovery. They're also less expensive to start up and operate. So there's a wonderful return on investment. And we have a really neat tool we call our economic calculator that we actually provide a cost benefit analysis for recovery housing, RCOs, other types of recovery programs to really be able to show the value that they're bringing to their communities. All right, next slide. So just further talking about how recovery housing creates value, again, it provides that safe, supportive environment and the community of peers. This is probably one of the most important, and we're starting to see it across the nation. We're starting to see peer supports in Kentucky. Peer supports are billable. They're an integral part of every recovery ecosystem in Kentucky. We use and have peers in our hospitals, in our jails. They're just critical to the recovery journey. And so recovery housing has been doing that for a long time. So when somebody enters a recovery house, they are really introduced to a community of peers who motivate one another, who just offer guidance and accountability to one another. That's just very special. I call it the special sauce. And then recovery houses really address the key health-related social needs like housing, employment, and social connections. I always say that, you know, for people to want to enter recovery and stay in recovery, it's all about helping them build a life worth protecting. That was a key for me in my own recovery, was like getting a career pathway. My education and career pathway that I've been so passionate about has been extremely crucial to my long-term recovery. Next slide. And then I'm a visual person, so I always love visual aids, but this is what we kind of consider the theory of change behind recovery housing. And on the left in the teal, you can sort of see not only the referral sources, but also some of the barriers that these folks are facing in the community. So they may have criminal justice involvement. They may be coming from a hospital setting. They may be referred by a counselor or treatment provider. Or community support like children and family services. I worked with a ton of clients who had an open children and family services case and were at risk of having their children removed. And then you'll also see individuals who are self-directed into recovery housing or other types of supports. And then in the middle, you can see again kind of a different representation of that service mix. We hope they'll receive either in the home or through partnerships that the home coordinates within their community. And then on the other side, seeing them have social support that goes well beyond their time in the home. And I feel like that's something that was really special that we saw in the Recovery Kentucky model I worked in, is there was a long-term relationship. There was a kinship and a bond. Still to this day, when I meet an alumni from that program or another staff member who worked in that model, there's an immediate bond and kinship that we all went through that similar experience together. And it's carried on well beyond my years as staff, and the same is true for the alumni. And they were such an integral part of the program. And then, of course, housing, transportation, employment, all the things we hope somebody is able to build in their life in recovery. And so, you know, whether we're talking about clinical services or whether we're talking about recovery housing or some other component of the recovery, they all make up the larger recovery ecosystem. And I always say that every community has a recovery ecosystem, whether it's working well or working as good as it should be, is something I think we should all be striving to evaluate and work towards, is improving our recovery ecosystem. And it's really what we do at the Fletcher Group, is to not only help develop things like quality recovery housing, but just expanding the recovery ecosystem in general. And I believe somebody's going to put in the chat a video that we have that explains more about what is the recovery ecosystem. And then on this slide, we really represent some of the different components or stakeholders of the recovery ecosystem. So the criminal legal system is very involved. And I was very fortunate to see, and I've seen this personally work very well, and I've seen them be very siloed where they're not working together. And when I've seen it work well, for example, our local hospital, when I was working in recovery housing, had an angel initiative. So when they had somebody present at the hospital that had a substance use disorder and that might be a good candidate for our housing program, they would call us and we would send a peer there to meet with that person, just to tell them, share their lived experience, offer them an opportunity to come to our program, or if that wasn't a right fit for them, to help them connect with a program that was more appropriate for them. We worked a lot with our faith-based communities. They would come in and feed our residents. It was always optional for residents, but they were a great support. That human services we worked very closely with our children and family services to help our residents reconnect with their families and get back on track and any issues they may have with that. So when a recovery ecosystem is working well, all of these components work well together. They don't stay siloed. And then this is kind of a different representation of the recovery ecosystem. It has the kind of different components. There may be diversion programs, treatment programs. And we like to say that it all starts with safe and supportive housing. But the point I really like to make on this slide is the final kind of proof at the top, because and I think that's been maybe a challenge for recovery housing especially until more recently, is we have to have proof. And even if you're having to start data collection in an Excel sheet or even on paper, start collecting. And that's something we can help with, is try to help you at least identify some key things you could be collecting data on and evaluating. But there are so many programs that are doing good work, but are we able to verify that? Are we able to put it in a grant application? How many people successfully completed our program? How many alumni have stayed in long-term recovery beyond our program? So that's just something to think about and to focus on with the evaluation piece. And then this is probably one of my favorite slides, because I probably have hit on this a little bit much. But, and as a clinician myself, I say this with a deep love and appreciation for clinical work, but clinical care is not enough. Medical outcomes rely on more variables than just the clinical care. You have the socio and economic factors, the actual physical environment that people live in. And I learned this when I left a long-term residential recovery housing setting and went into outpatient. I learned so quickly that I could offer the best treatment and be the best clinician in the world. But if they were returning when they left my office to an environment that was not conducive to long-term recovery, where they just faced just horrific challenges in some of these cases, that the chances of them being able to enter and maintain long-term recovery were very slim. And so this environment is so critical to long-term recovery. And now Milena is going to talk to us more about how we're seeing the social and medical models align on a national level.
Thank you, Erica. Before I transition into the next slide, I want to say a little bit more. Part of my experience that was shared was really more that macro level experience. But I also ran and operated a 75-bed recovery program and an opioid treatment network. And I found my way to working in the recovery housing and housing space because housing is a crisis for the individuals that were accessing our services. That I had data from withdrawal management and long-term inpatient settings that was suggesting that a lot of the folks that were accessing our care were unstably housed and had complex substance use challenges, but medical and behavioral health, mental health challenges as well. And so when we talk about the alignment of social and medical models, we're talking more than just about aligning recovery housing with substance use services. We're talking about aligning that entire ecosystem that Erica is talking about, and that recovery housing is a place where folks are addressing their health behaviors and their socio and economic challenges that are long and historical, often rooted in ACEs, adverse childhood experiences and trauma. And so really the goal is to create a system of care that is addressing all of those challenges, not just stabilizing the medical components, which is a nice transition to this next slide. So what is ASAM 4th edition and why does it matter? So ASAM is the level of care criteria that's utilized by the medical system to define the treatment course or the episode of care that an individual with a substance use disorder experiences. And so 45 state Medicaid programs use it, and 26 states provide coverage for the services in ASAM. So, you know, they have a significant footprint in the health system. As a substance use counselor and social worker, I was trained in ASAM as well, and it's what I used. It's the language I used to get my clients access to care. But the beautiful thing about ASAM is that their 4th edition really focuses on a few themes, and really it's, you know, these elements of intoxication and withdrawal, and that's where services start, not end. So really this element around continuity through the system following, you know, a medical episode. You know, they're really focused on how safety and risk affects the individual's recovery. The dimensions address the safety and risk. They address the medical and the psychiatric and cognitive conditions. They are also addressing risk and recovery environments and person-centered considerations, right? And really this idea that recovery is not linear and it's different for everybody. And the idea is that if you start treatment, you need continuity through recovery support, you know, to achieve full sustained recovery. And so recovery housing really focuses on how do we bridge these services that are happening in dimensions 1 through 3 and place, you know, continuity among folks in the community following those services. Their new framework also considers recovery supports and this idea of recovery capital. Now that, you know, a lot of research has been done on the role of recovery support and the impact of recovery support, you know, there's evidence for funding and supporting these services. And the idea really is that they work in tandem to help that individual progress through their goals, that it doesn't just stop at stabilization. So what is recovery capital? For those of you who haven't heard this term, there's, you know, this is a nice framework. There's personal capital, which is the gifts that individual is born with, their health behaviors that lead to enhanced wellness. There's social capital, the social conditions and supports. And then there's cultural capital, beliefs, spirituality, sense of purpose, sense of community values. Culture varies in, you know, different communities as well. But, you know, in a nutshell, that's what recovery capital is. It's about that person's wellness and their environment. And so, you know, what's their guidance today? I mean, this is new. This is hot off the press, you know, around referrals to recovery housing and supports, right? So when you're evaluating somebody's need for this service, the ASAM guidance is really around that individual's ability to function within their current environment related to their both physical and emotional safety. And then the likelihood of re-engaging in risk behaviors or ability to keep themselves safe in the community. So if the person isn't able to do that independently, it's a good sign that a recovery community might benefit them well. So what are the other things to consider too when, you know, when we're talking about measurement and what's working? One of the frameworks that is used to support the type of care that patients with substance use disorder experience is really this chronic care model. And it stems from chronic diseases like diabetes and heart disease, which, by the way, may be comorbid within the individuals with SUD. But it really focuses on helping individuals develop their self-management skills, access the right services, have decision support around the services that they receive, and then, connection to health and community. The other thing that's important to understand is, and Erica talked a lot about outcome, is this idea of measurement-based care. So in a chronic disease model, we're looking for improvements, and we have to measure those improvements over time to suggest that what we're doing is working and that what we're doing is what the person still needs. I included here, since we're talking a lot about research and outcomes, there's some links to these articles and presentation on Recovery Capital for those of you who want to learn a bit more. You saw this earlier in the presentation related to, 1 through 4 levels around recovery housing. In the development of ASAM's new guidance, we saw a partnership evolve between ASAM and NAR, and they created these 4 levels as defined in the new ASAM criteria and guidance. So peer run is that level 1 that you heard Erica mention at the start. A level 2 is monitored, which basically means that there's some sort of house manager that's organizing the culture of the house, the services of the house, the intake procedures. Level 3 is supervised. These can be facility or home-like environments, depending on the state. And supervised means that there's a service component that's added. And then the last is clinical. It means that those are typically going to be facilities in states, like your long-term inpatients. And they're going to have clinical staff on site for folks who need additional management. Maybe it's medical management, maybe it's behavioral mental health management. The other thing that we see too are partnerships, right? Because we talk about an ecosystem. So funding is complicated, and certification can be complicated. Workforce can be complicated. So we've also seen some partnerships come up where, folks are using outside providers to come in and enhance the level of care provided in the home through those partners and services. And speaking of partnerships, partnerships between treatment and recovery providers are important and explicit in a chronic care model. The idea is really that these folks are working together, that individuals are encouraged to access community programs, and that leadership within those programs have communication with one another and intentionally discuss how to fill gaps in needed services. In Washington, a lot of this is evolving in the medications for opioid use disorders. The NAR affiliate here in the state of Washington is looking to develop guidance and support around supporting recovery homes in managing patients and helping patients on MOUD access appropriate services. Last but not least, the CMS Innovation Center is also shifting its funding and its grants to look at these, health and housing models that really improve patient care and lower costs. The rationale being that if the symptom or the challenge or the barrier that you're trying to solve is not medical, the solution doesn't live in that system. It lives through partnership. So what is working? So in Washington, to promote some of these integration efforts, there was, legislation to support access to rental assistance and startup grants, and the Medicaid waiver to establish housing case management and employment support programs, where you're really bridging the health and housing systems together. In New Mexico, the Federal Recovery Housing Pilot Program has opened new sites. And then in Kentucky, there is a waiver to support case management services. And I'm going to get some water and turn it over to Erica to finish telling a little bit more about Kentucky because she's close to it.
Thanks, Milena. And you've also got the Recovery Kentucky Centers in there. That's the model I mentioned. I say the model that raised me. And so we have an exciting new project. In the next slide, we're going to share that really is an extended or expanded version of the Recovery Kentucky model. So this is something we saw work very well, that particular model. Again, for over a decade, it has outcomes backing it. It's been named an evidence-based program by SAMHSA. And so we help other communities. We help communities large and, well, all rural communities develop programs large and small. The Roar Center is an expanded version of the Recovery Kentucky model, but it is in my opinion, perfect example of aligning social and medical. This is a beautiful new $14.5 million facility in Kentucky that we drove the development for. And you saw a rendering of it, but the actual building is there. They had their grand opening in May. It has 100 recovery housing beds for women. And what we expanded about it is it offers counseling on site. So it has an outpatient clinic on site. So there's your clinical component coming into play. It has a very large focus on workforce development. There's a partnership with the local college. They'll have access and care coordination to get medications for opioid use. And then one of my favorite parts of this program that we've also added is a family reunification component. So the women there will be a lot of focus around family reunification with their children, extended family. There's a community center for visitation and things like that. And then there's also 12 family apartments where they'll be able to apply for an apartment and stay indefinitely if they have the need for that longer term housing and continued support. So it's just a model we're really excited about. And again, it just opened in May. So we thought we would share that as a good example of an alignment between the social and clinical models that we've personally helped with. And then we're just kind of wanted to get some feedback and do a temperature check and ask who's in your recovery ecosystem. And I'll go a step further to say, how are you collaborating? Because the components of the ecosystem are usually there. There's usually the shell, but or at least where I see challenges in my own community is that they don't always work well together. So if you want to put in the chat, who are some of your key partners, we'd love to know that. And then, Milena, you're fine to move on forward while we're waiting on some of those responses. I wanted to, again, just thank our sister program or sister center of excellence, the University of Vermont. Again, there are 3 rural centers of excellence, Fletcher Group being one, University of Vermont, and the University of Rochester. And between the 3 organizations, we really cover the gamut from prevention and stigma reduction all the way through to treatment and recovery. So I don't see any responses yet, but any final thoughts from you, Milena? And I believe we're going to take some questions as well.
No, thank you, Erica. Excuse me while I get my voice back. The final thought for me really is ecosystems work together when people are communicating and when they're able to safely and openly discuss the challenges. One of the tensions that I see in ecosystems is, because resources are limited, people can feel like they're competing for resources and they may adhere to certain philosophies or ideologies that divide rather than, unite our cause. And so I guess the message really is that recovery looks different for everybody. And each intervention is an opportunity to engage somebody.
Absolutely.
Thank you. This is wonderful. I'll go ahead and share my screen now. And in just a sec, we will move on to the question session of a portion of our session. But right now, I'm going to launch a poll and just give you all about 1 minute to answer these questions. And again, thank you everyone for attending, and thank you so much to our speakers for this wonderful presentation. It's very thought-provoking and interesting. Something we don't talk about as much at UVM CORA, so it's so welcome to have this topic to discuss today. And I'm just going to give people another few seconds here to finish up the poll. All right. Let's see. All right, well, thank you. I'm going to end the poll, and for folks that didn't get a chance to answer, don't worry. It is you're still going to get your continuing ed. And speaking of which, you will receive an email next week with the recording and the slides for this webinar and instructions on claiming continuing education credits. We're also sharing that link in the chat, so if you look through the chat, you'll find it. Our next community round session will take place on Wednesday, September 18th. We are happy to welcome Dr. Lisham Ashrafioun, who will present Addressing Stigma at the Individual, Provider, and Community Levels. Please save the date. We're going to open that registration soon. You already saw this, this graphic here about our sister organizations, and we were very excited that folks from the Rural Center of Excellence on Substance Use Recovery at Fletcher Group could join us today from Kentucky. I will now hand it over to Eleanor Broy, who is going to facilitate your questions.
Thank you both for such an informative presentation. I'll now read through some of the questions we've received. Firstly, can you discuss funding sources for the kind of long-term housing, two-year housing, and are any of them publicly funded?
Hi, Eleanor, I'd be happy to. So I can share with you a few resources. So at the federal level, HUD has the Recovery Housing Program. It was funded under the Support Act, and states have gotten roughly about $1 million a year. 25 states are participating, roughly $1 million a year since 2020, maybe it was 2019. So that's a HUD funded program. In terms of capital funding for developing sites, we also look at HUD funding, and then different states have their own programs and how they prioritize that funding. And so one of the things that we do with folks is help them review and understand what that looks like within your state if you're a rural partner. And then related to Medicaid dollars, we have seen some states create Medicaid waivers and states blending substance abuse block grants and mental health block grants and SOAR grants to fund rental assistance. These are often tied to Medicaid services. People get clinical access and they're referred to a network. We also see Medicaid waivers funding things like employment services and housing case management in terms of service income for recovery housing, as well as peer services. And those services fund recovery housing. Related to development, there's also some like USDA types of grants and things like that. And then, you know, for employment programs, there's grants for that, right? So a lot of what we do is we sit down and we look at your landscape. You know, the criminal justice system, sorry, one more big source of funding. The criminal justice system funds a lot of housing vouchers for folks exiting jails or prisons. What we see though is that the funding is typically restricted to a population, and usually you have to be in a risky situation to access those funds. So other than that, then you're looking at like homeless prevention dollars and homeless system dollars for mainstream. So I hope that answers your question. It's a complicated answer, I know, but those are kind of some general places to start.
Great, thank you. And then can you point to some studies on outcomes of long-term recovery housing?
Yeah, so I think so. A few of those that we cited in the PowerPoint, those studies offer some of that. And then certainly like if you look at the cited resources within those, right, you would get the access to them. If you are interested in reaching out to Erica or I can connect with our research team, and together our rural centers have a clearinghouse that's kind of that's evolving in conversation. So I'll say that. And the goal of that is really to promote and disseminate the research, to share with you all the resources that you need to move your work forward.
I'll also put the Recovery Kentucky outcome studies, because as far as recovery housing goes, again, it was a level 3 facility. It's one of the most studied long-term, kind of with longitudinal data that I know of. So I put their most recent 2024 outcome survey there if you are interested.
Thank you so much. Next question, do you have any tips on how to engage stakeholders, and who do you engage with?
Ooh, that is a great question and one of my favorite subjects. So I love to share that I'm a community organizer at heart. So everything we do starts with an environmental scan, where you're really looking at reports, data, resources that are available in your community. You're understanding kind of the structure of the community, who the providers are. You know, depending on if you're doing individual outreach as a provider to provider versus trying to organize a stakeholder meeting, that process could look a little different. But typically, you know, I start with a question that I'm trying to answer, and I reach out to friendly folks that I know are connected to the question or the answer that I'm trying to solve. And I meet with them for coffee, and I don't always have an agenda, right? My agenda is more like to know them and understand what's meaningful to them and understand their work and help them understand my work. And really, I'm looking for what's our alignment in values and goals before I do my sales pitch. So that's my response. Erica, do you have other thoughts or suggestions around this question?
I saw in the chat someone put it depends on the area, and I would agree with that. And so I always caution folks to, you know, kind of get a good idea of who your allies are going to be, but also it's just as important to know maybe who's not going to be excited about your project or the effort you're trying to pursue. So I agree. I say, you know, kind of your suggestion to pursue friendly folks that you know will not be at least against your project is really important starting out.
And then develop a stakeholder log, right? And what their relevance is to your question or project. And then, you know, that log kind of becomes your future outreach.
Well, I think we'll probably stop it there. And again, thank you so much, Milena and Erica, for joining us today and for bringing your very interesting information, very informative and helpful, I think, for this audience to learn about. And thanks everybody who attended. As always, if you have any further questions or comments for our presenters or for CORA, feel free to contact us at cora@uvm.edu, and we hope you have a wonderful afternoon.
Thanks, everyone.